Hi, I'm John Mascarenhas. I'm a clinical investigator at the Icahn School of Medicine at Mount Sinai. The question being posed, do you need to combine a JAK inhibitor and a BET inhibitor together to enjoy synergistic activity? I think the answer is yes. Preclinical data provided by the laboratories of Dr. Levine and Kleppe would suggest that the drugs work best in combination, synergistically, in murine modeling of MPNs. And the clinical data that's emerged from the MANIFEST study to date would support that. Whereas you get modest activity as monotherapy, the best activity was seen in the second cohort of patients that we treated in a salvage manner, adding CPI-0610 to ruxolitinib in order to either address anemia, splenomegaly, and assess symptom burden. And the combination together was clearly effective and well tolerated. Therefore, a cohort 3 was eventually opened, which was adding CPI-0610, the oral pan-BET inhibitor, 14 days on, 7 days off, and a 21-day cycle to a stable dose of ruxolitinib in JAK inhibitor naive patients. These were patients who had splenomegaly, who had symptom burdens, and the data that's presented, that has been presented at ASH 2019, but also now updated in 2020 at EHA, would suggest that there is considerable activity using this drug up front with spleen volume response rates of about 60%, symptom response rates similarly, and even improvements in hemoglobin. We don't get the same kind of depth of anemia that you get characteristically with single-agent ruxolitinib, and the mean hemoglobin level would even appear to be above the baseline after 6 months of therapy. Additionally, we see a reduction in bone marrow fibrosis, and the tolerability, I think most importantly, of the combination would allow this type of therapy to be considered as an upfront therapy. And for that reason, a pivotal randomized phase 3 study will start later this year, combining ruxolitinib to a CPI-0610 to ruxolitinib versus placebo to ruxolitinib in patients with DIPSS intermediate or high-risk disease, splenomegaly, and symptom burden who are JAK inhibitor naive. And that, to me, is going to be a very important study to both determine whether the rate of spleen response is better than single agent, the depth of spleen response is better, and in my opinion, a very important endpoint would be the durability of spleen response is better. We know that patients on ruxolitinib who enjoy benefit, and most do, eventually most of those patients lose benefit over time, and within 3 years, half the patients discontinue therapy, and their outcomes, unfortunately, poor. So therapies that we're using up front to synergize with it would have extra benefit and extra clinical meaningfulness if they could extend that duration of benefit and avoid the inevitable progression of the disease and spleen that leads to discontinuation and poor outcomes.